Good evening, everybody, and welcome to our joint ISSM-ESSM webinar. We are very excited to have three great speakers who will show us the importance of integrating sexual health in urologic and gynecologic surgery. My name is Elisa Mazzeroli. I'm joining you from Florence, Italy, and it's my privilege to represent the ISSM today as the chair of the webinar subcommittee. The option that you can see here in the slide is the one that allows you to add automated subtitles, including translations. So you can turn these on and off at your convenience, just selecting the show captions option in the lower part of your screen. My co-chair today is Dr. Daniel Osmorov from Germany. He's representing the SSM and will present the SSM later on. So the ISSM is an international medical society. We are dedicated to the study of human sexuality, and we believe that every human being has the right to a healthy and satisfying sexual life. And we do that by our mission, which is we are hoping to become the most respected source for information, education, and professional development in the field of human sexual health. And of course, we are trying to achieve this through world-class publication, research, and also in-person and online opportunities like this webinar to exchange our knowledge worldwide. We have several affiliated societies with representative and members joining us from all over the world, and this is in line with our mission to develop and foster research also in all the countries. And we have also several journals which are available both via print and online: the Journal of Sexual Medicine Open Access, Sexual Medicine Reviews, and the Video Journal of Sexual Medicine. And they are all great opportunities to share your research and to learn about sexual health. Next, please. My co-chair and moderator is Dr. Daniel Osmanov, and he's the chair of the SSM Educational Committee. And I'll hand it over to Daniel to talk about the SSM.
Thank you very much, Elisa. Thank you for your introduction. And I'm more than happy to support this great initiative. We talked to Elisa a couple of months ago, and the idea came from Elisa Mazzaroli to have our combined or joint webinar together with the International and European Society for Sexual Medicine. I would like to give some ideas, and maybe we can collaborate and have our joint projects in the future together with the ESSM. On behalf of our president, Mikkel Fode, I would like to encourage you to join us in Portugal, in Porto, in February 2026 during the meeting of the World Meeting of Sexual Medicine, which will be in next 2 months. We have a very nice project, ESSM podcast. We already have 2 podcasts dedicated to low sexual desire, episode 1, and episode 2, a truly minimally invasive procedure changing men's lives. They are all available on ESSM. You have to be ESSM member or combine ISSM and ESSM member in order to have an access to our podcast. Another great initiative, we already had our ESSM or legendary ESSM school, an advanced course of sexual medicine in Budapest in the end of November 2025, as well as EFUS, which is a great initiative from Elisa, ESSM Female Ultrasound School, and we will continue this project next year, and the dates for 2026 will be published on our homepage. Again, please visit us in Porto, in Portugal. We have not only European Society, we have International Society for Sexual Medicine. This is a joint meeting, and this is the World Meeting on Sexual Medicine 2026. Today, I would like to present first speaker, a friend of mine, Professor Koen van Rettenhem from Belgium. He is a chair of urology in Hasselt in Belgium, which is very close to Brussels. He will talk about combined surgical treatment in patients with erectile dysfunction and severe stress urinary incontinence. We call it 1,500 procedure. He will explore the implantation of both penile prosthesis and sphincter prosthesis. And we have another two doctors. Elisa, you wanted to introduce them.
Yeah, we have Alison Poland. She's joining from the US, and she will talk about female sexual function after anti-incontinence surgery. And then Dr. Anna Padova from Israel, and she will present her talk about POP surgery and sexual function. Then we have, I hope that we will have an engaging Q&A session, and you can submit your question already during the presentations by the opposite Q&A feature. Thank you.
So we will start with our first presentation from Koen van Vredenhem to surgical treatment of ED and stress urinary incontinence.
Thank you, Danyar, for your kind introduction. Thank you, Elisa. I would like to give you, I will try in 15 minutes to give you a little insight in the surgical treatment of a patient with an erectile dysfunction and a severe stress urinary incontinence, which is in patients after radical prostatectomy quite often a problem. Next slide, please. So these are my disclosures. Next slide, please. As Danyar mentioned already, AMS, Boston Scientific, is a company who has the two devices available on the market, which means they have a sphincter, which is called an AMS 800, and they have also a penile implant, which is called an AMS 700, and 800 with 700 is together 1500, and urologists like to talk about AMS 1500 when we refer to a dual implant or a double implant. Next slide, please. You should realize that even with robotic treatment, surgical treatment of localized prostate cancer, we see that there are quite a lot of patients that will suffer from erectile dysfunction. And in the literature, these numbers differ from a quite low number to a high number, but I would say that it's quite realistic to say that up to 50% of patients after radical prostatectomy might suffer from erectile dysfunction. That, unfortunately, in many cases, will not respond to PDE5 inhibitors because of the neuronal damage. There is no NO, nitrogen oxide, available, and this makes that PDE5 inhibitors quite often do not work and are not efficient. We also see to a lesser extent that there are quite some patients, up to 1 out of 3 patients, that will suffer from severe stress urinary incontinence. And this can be treated also conservatively with pelvic floor muscle training, penile clamps, alpha agonist, but also here in many patients, this stress urinary incontinence is resistant to conservative treatment. And then we need to talk about surgical options. Next slide, please. Historically, IPP, so inflatable penile prosthesis, and AUS, artificial urinary sphincter, is a two-step strategy. So if a patient has both conditions, you can choose to first implant a penile implant and the sphincter, or the other way around. It is, however, evident that you can propose a patient to have a combined surgery in one single operation. And when we look into the 1980s, when the devices were on the market, 1973 was when the first penile implant became available, and then later on the sphincter. Well, at that time, in the early years, when they tried to do a double implant, there was a 100% revision rate because of fistula, abscesses, infections, etc. So in many cases, the first step was to treat urinary incontinence because this is more bothering to a patient. And artificial urinary sphincter is classically done through a perineal incision for the cuff placement, and then a second counter incision in the inguinal region to insert the reservoir. So these are already 2 incisions. And then in a second surgical time, you can do the implant of the inflatable penile implant, which can be done intrapubic or penoscrotal. And there are a lot of surgeons who do this, also this penile implant with 2 incisions. So this makes 2 operations and 4 incisions. Steve Wilson, the godfather of prosthetic urology, suggested that we could do artificial urinary sphincter also with a penoscrotal incision. Because for the penile implant, we already tried to do penoscrotal access, but for the sphincter, this was not the very classical way to do. I do now penoscrotal sphincter implantation for more than 10 years, and we published so far 2 papers. One has been a smaller series of 40 patients, another series that has been published 2 or 3 months ago in IGIR was on 160 patients. This is a retrospective study, but there we could see that there is absolutely no inferiority if you compare penoscrotal sphincter implantation to perineal. I can tell you that I'm also part of the Saturn trial from the EAU Research Foundation, and Saturn is a prospective data collection of surgical treatment of male incontinence with sling and sphincter. And in this database, we have already statistically analyzed the difference between perineal and penoscrotal sphincter. And in this prospective series, we can confirm that a penoscrotal sphincter is a very good option if, of course, the operation is well done. Next slide, please. So again, in 2003, when Wilson started proposing the penoscrotal approach, we saw that more and more surgeons were prone to try to use this incision. If I run through the operation, many people ask me if you do a double implant with 1 incision, so a single scrotal incision, do you do first the sphincter or do you first the penile implant or the other way around? Well, the answer is that I do this mixed up because the biggest fear in prosthetic urology and in prosthetic surgery in general is infection. We are afraid to have an infection, and the most important parameter maybe for infection prevention is the duration, the time of the operation. So the longer the operation takes, the higher the risk of infection. So I try to mix both procedures to speed up the operation. So the first thing we do is we aim for the bulbar urethra. And there it is key important that you get as proximal as possible, because if you have a perineal sphincter implantation, you are at the level of the crural bodies of the corpora cavernosa. So you need to be very proximal also with the penoscrotal incision, which is absolutely feasible. And we published that we are at the same level as a perineal approach. After measuring the size of the cuff of the sphincter, the operation moves on with the corporotomy. So we open the corporal bodies of the penis to measure the length of the cylinders that will be needed for the penile implant. And this incision in the corpora, the corporotomy so-called, is a little bit distal to the side of the cuff in order to prevent any interaction between cuff and cylinders. Next slide, please. What is important is I have in my consultation, but also in the OR, dedicated nurse specialists. And when I do a surgery, there are 4 people. There is me, the surgeon. I have an assistant in front of me who has also quite some experience in prosthetic urology. We have a nurse taking care of the instruments. But very important, there is a nurse who prepares both devices. And when I start with the incision, the nurse already prepares both reservoirs that we need for both devices. So by doing this, I measure the cuff size, I measure the corporal length, and when I've done this, the reservoirs of both devices have been prepared, so I can insert the reservoir of the IPP, the penile prosthesis, and on the other side, the reservoir of the sphincter. Then we can insert the cylinders, which is the artificial corporal bodies. And then we have also the cuff of the sphincter. And then we have all the elements of both devices in place and we connect everything. Next slide, please. I will demonstrate in a video. Next slide, please. Yes. So you need to create some space for the pumps. You need to connect everything. You need to close everything. We deactivate the sphincter and we inflate the penile implant. Next slide, please. What I told you is you need an experienced team, and you do not need to divide the procedure in two parts. So not first sphincter, then penile implant, or the other way around. And I can tell you that when I made this presentation, normal operating time skin to skin was 45 to 60 minutes, and skin to skin means from the moment that you do the skin incision until the moment of the last stitch or staple to close the skin. Well, I can tell you that nowadays we do this operation in between 30 and max 40 minutes. And this is a very short operating time, which is related to a lower infection risk. Another thing is that I mentioned about dedicated prosthetic nurses on the outpatient clinic. The patients will be seen pre-op for counseling, but also post-op for wound control by the prosthetic nurses many times. And by having this experienced team, this will make your outcome better. Patients get also a prophylaxis of antibiotica for 1 week, since we have a double implant and we want to prevent by any means infection. Next slide, please. This is, I don't know whether you can see this, but this is my technique that I published together, by the way, with Professor Osmanov, because we did the studies also in the Kiel Anatomy Lab where Danyar is working also. And one of the problems with reservoir placements is that you have a risk for herniation. And by doing an incision in the external fascia, you can prevent herniation. Next slide, please. These are two papers that we published, and if I look into the figures that might be important, I just highlight a few of them. So the operating time, 45 minutes average. Nowadays we have between 30 and 40 minutes. The cylinder length is average 20 centimeters, which is absolutely comparable to the single penile implant or inflatable penile prosthesis implantation. The average cuff size is 4 centimeters, which is also comparable to the average cuff size in perineal sphincter implantation. If you look at the outcome, you see that we have a social continence of over 90%. I would say that is anyway more than 80%, and socially continent means the patient needs not more than 1 pad a day. And this is a very good outcome. If you look at the satisfaction rate for the penile implant, you see also that the patient and the partner satisfaction rate is way above 80%, which is completely in line with the literature on the separate implantation of both devices. Next slide, please. So this video is available on the platform of the Video Journal of Sexual Medicine. Shoban, you can fast forward a bit, because I just want to give an impression. For the sake of time, it's better that we move on. So you see the explanation of the patient case regarding his incontinence, regarding his erectile dysfunction. You can move on a little bit. Then you have some explanation on how the operation is done. You see in this patient, we only need 35 minutes. These are the practical details on the device characteristics. And this is the operation. Yes, this was okay. So this is a single penoscrotal incision. And if you were very attentive, you might have noticed that I mentioned I do this with a transverse incision. What you see here is a vertical incision. And for a couple of years, I changed my technique from vertical to transverse to vertical incision. So these videos are available on the Video Journal of Sexual Medicine, and you do not need to be a member of ISSM, of ESSM. They are freely accessible because this platform is supported by both device companies. You can see that the video also has, once in a while, every time we have a new critical surgical step, you see that there are some nice anatomical drawings. So there we go deeper and deeper. If you want to see again, if you want to see the video, just go to VGSM. I told you already that if you look into the literature, you will find very few papers that are published on a double implant. There are many times retrospective data. I talked already in 1982, the first paper on 4 cases with a 100% complication rate. So you see that there are several papers now available, but all on lower numbers of patients. Next slide, please. This is a rather big series from Parlak and Barrett on 60 patients, but they did a double incision, which is, I think, a disadvantage compared to the single incision that we do. If you see that there is an erosion and infection risk of 11%, this is far too high. In prosthetic urology, infection rate in normal patients, so virgin cases, should be around 1%. And in our series of double implant surgery, we have also less than 1% infection rate. So this is a very high infection rate. One of the nice papers that have been published on this topic is by Juan Salamanca from Madrid. He published the paper on 32 patients, and as you can see, with a high continence rate and good outcome of the IPP. Next slide, please. Another advantage, of course, if you do one single operation is that you will not only have a time benefit, but also a cost benefit, which can be important, I think, in most of the countries. If you do a single operation, you will have a reduction of cost because you only have one single hospital admission. In this figure, you see the advantages and disadvantages of the single incision dual implant. This is from the paper that we published, and the advantages are quite logic: shorter operation time, one incision. You have a better outcome concerning pump and reservoir migration. You only need one anesthesia. You only need one hospitalization. You only need to recover once from the operation. So it will be cost saving. And for the patient, he will have less working day lost. Disadvantages, well, don't underestimate the difficulty of this operation. So it takes for the surgeon a longer learning curve to be able to do this with a good outcome. And especially the proximal dissection of the urethra might be very challenging. Next slide, please. I think that we are more or less at the end of this presentation. So a dual simultaneous, as we call this, AMS 1500 implant is possible. But as I highlighted, you have to do this in an experienced high-volume center, not only with an experienced surgeon, but also with an experienced team, as well in the OR as in the outpatient clinic. We proved, and you see in the literature, that if this has been done properly, the outcome, if we talk about functionality, infection rates, device survival, is comparable to the separate two-stage operation. I think that one single penoscrotal incision is, of course, advantageous if we compare with several incisions. I mentioned one single anesthesia, one single hospital admission, and cost saving. Next slide. So this was, as I told you, my last slide. I guess we move on to the next presentation and we take the questions in the end, Elisa, or...
Yes, if you can stay, yes.
Oh, I will. I hope I was a little bit in time. I don't know how long I talked.
Thank you for staying in time and for the illuminating talk. So now we will proceed with Dr. Alison Pollan, MD. She's the director of the Pelvic Floor Center at Maimonides Medical Center in Brooklyn, New York, and she will talk about female sexual function after anti-incontinence surgery.
Okay, perfect. Thank you. Thank you for the opportunity to speak. I'm excited to talk about anti-incontinence surgery and its effects on female sexual function because we have so many patients with incontinence and there are so many women treated with anti-incontinence surgeries. And there's a lot of different hypotheses regarding the association between incontinence and sexual dysfunction. And those include, for example, low self-esteem due to incontinence or fear of incontinence during sexual activity. And so it's been suggested that the improvement in sexual function that results from treating the incontinence is just because of an improvement in urinary function. But as you'll see in this talk, that's not always the case. And so there may be effects of some of the treatments we use for anti-incontinence surgery that directly affect sexual function. I have no disclosures. So today we're going to talk about the types of incontinence. There's urgency incontinence, stress incontinence, and continuous incontinence. And then we're going to talk about the effects of treatment on sexual function. And we're going to really focus on surgical management. Next slide, please. So let's talk about overactive bladder and urgency incontinence. Next slide. Overactive bladder is a symptom complex, and it includes urinary urgency, frequency, and urgency urinary incontinence, and it's in the absence of other pathology or infection. And it's really a clinical diagnosis. You do not need additional workup like urodynamics to make that diagnosis. Next slide, please. This is the American Urological Association's overactive bladder algorithm, and it's hard to see on this slide, but I want to just go over the highlights. So step one for every algorithm is always conservative management, and that's behavioral modification here. So I have patients who come in and they tell me that they measure their coffee intake in pots of coffee rather than cups of coffee. That's too much caffeine. That's going to cause overactive bladder. There are also some patients who say they go urinate every 30 minutes just in case. And for those patients, we talk about timed voiding, stretching out the intervoid interval so that they're not urinating so frequently. And then, traditionally after behavioral modifications failed, we then directed patients to medications like anticholinergics or beta agonists, and then moved on to next line therapies like posterior tibial nerve stimulation, onabotulinum toxin injection, and sacral neuromodulation. But the newest algorithm from the AUA says we don't have to do this stepwise approach, and we really need to have a discussion between the physician and the patient about how we can kind of move straight to next line more invasive options if it's appropriate for that patient. Next slide, please. So the three invasive treatment options for overactive bladder are posterior tibial nerve stimulation and implantable tibial nerve stimulation, cystoscopy with botulinum toxin A or Botox injection, and sacral neuromodulation. So starting with posterior tibial nerve stimulation, it's an electrical stimulation of the posterior tibial nerve that results in retrograde stimulation of the sacral nerve plexus, and that's going to cause a central and peripheral suppression of the efferent nerve activity, and that relaxes the bladder. And so it can be done percutaneously or with an implantable nerve stimulator. Next slide, please. This is showing the percutaneous nerve stimulation, and it's been around for longer, and there's more data on it. So I want to start with that, and then we'll go on to describe the implantable options. The stimulation is delivered via a 34-gauge needle. It's kind of like an acupuncture needle that's placed into the ankle, into the posterior tibial nerve, and the patients undergo a series of 12 weekly treatments for 30 minutes each. And patients who have improvement then often go on to monthly maintenance sessions. And this is really the least invasive option of the more invasive options for overactive bladder. And it's been shown to work better than placebo and equal to medications like tolterodine. Next slide, please. So there's some basic science research showing increased vaginal blood perfusion in rats with posterior tibial nerve stimulation, but there's really limited clinical data. There are a couple smaller studies showing improvements in all domains of sexual function with the PTNS. And I want to highlight a study by Musco and colleagues that found improvement in sexual function that was not correlated with improvement in urinary function. So this led the authors to suggest that the sexual function improvement might be directly related to the nerve stimulation rather than simply due to improvement in urinary symptoms. And then because there were really only small existing studies, a review and meta-analysis was performed, and this found that 4 out of the 7 studies included reported a positive effect of PTNS on sexual function. And in the meta-analysis of those 4 studies, there was a significant improvement in sexual function with PTNS. Next slide, please. Many patients don't have the time to come in for weekly treatments, and so implantable tibial nerve stimulation was developed to provide the same treatment without the need for weekly visits. So these devices are implanted typically under local anesthesia, and there are 3 companies making these devices now that are available in the US. There's Ecoin and Altaviva, which both include the battery, whereas Revi is a device that requires the patients to wear an external ankle band, and that delivers the stimulation. And this stimulation is, fairly new in terms of the implantable version of tibial nerve stimulation. So I wasn't really able to find any studies examining the effects of this on sexual function. But if we extrapolate from the percutaneous version of this type of stimulation, we assume that there would probably be benefit. So the next treatment I want to talk about for overactive bladder is injection of onabotulinum toxin A into the bladder. Next slide. This is a derivative of botulinum toxin, and it causes paralysis by inhibiting acetylcholine release. And it can be directly injected into the detrusor muscle of the bladder using cystoscopic visualization. And it can be done with local anesthetic in the office or under sedation. And by injecting this paralytic agent directly into the detrusor, you relax the detrusor overactivity, and the patients have less urgency and frequency. There is a risk that it relaxes the bladder too much and the patients develop urinary retention, but this happens in only about 5% of patients, and the effects last 6 to 9 months, and then patients require repeat injections. A meta-analysis of 3 studies looking at the female sexual function index before and after cystoscopic injection of the botulinum toxin A had a total of 119 patients included, and the authors found a significant improvement in FSFI domains of desire, arousal, orgasm, lubrication, and satisfaction. Really, pain was the only domain that didn't show improvement, and the total FSFI also showed a significant improvement. So we have to assume in this case that this improvement is due to improvement in urinary symptoms. And the reason I say that is because injection of the botulinum toxin A into the detrusor muscle is not really thought to have systemic effects. And so it's unlikely that improvements in FSFI would be due to anything other than improvements in urinary function. So let's talk about sacral neuromodulation. I like to explain this to patients as a pacemaker for the bladder. I like the analogy because, as I explain to patients, if the bladder squeezes too much as an overactive bladder or not enough as a non-obstructive urinary retention, this can help. It's also approved for fecal incontinence. And it's placed in a two-part procedure, with the first part placing the lead and trying it out. So that can either be done in the office with a temporary lead or in the operating room with a permanent lead. And during the trial, the patient wears an external pulse generator. Basically, it's kind of like a battery on a belt. And then if the patient has a 50% improvement, they can go on to have implantation of the pulse generator. And so that makes the entire device internal. And in the past, these devices were not MRI compatible, but in the last 5 years or so, they have developed MRI compatible devices. And in the US, there are two brands on the market. There is InterStim made by Medtronic, and there is the Axonics device. Next slide, please. In a review of the effects of sacral neuromodulation on sexual function, 8 of 17 studies reported a positive effect. And a meta-analysis of data from 11 studies that included 573 patients showed significant improvement in sexual function. And the results remain significant in most subgroup analyses, except for those patients with fecal incontinence. Then there was a systemic review by Gyn, which found that sacral neuromodulation significantly improved dyspareunia in 9 out of 13 studies, which is pretty impressive. And there are a number of different hypotheses about that regarding the improvement in sexual function with neuromodulation. Because the thought is, well, maybe the neuromodulation strengthens pelvic floor muscle tone with bulbocavernosus contraction, placing pressure on the deep dorsal vein of the clitoris, and that sort of prevents venous escape and results in clitoral engorgement. That's definitely a possibility. The other thought is that maybe arterial flow might be affected by neuromodulation. And in women with sacral nerve stimulation devices in place, they've done vaginal pulse amplitude, or they've done vaginal plethysmography and found an increased vaginal pulse amplitude, suggesting that there may, in fact, be improved arterial flow. So, with sacral neuromodulation, certainly some of the improvements could be due to improvement in urinary function, but there really may be other mechanisms at play. And I think that's really interesting as we think about, could we use sacral neuromodulation in some other way and in patients who don't specifically have urinary incontinence, because it does seem to improve sexual function. So we're going to shift our focus from the overactive bladder and leakage with urgency incontinence to stress incontinence. So stress incontinence is leaking with coughing, sneezing, running, jumping, basically anything that's causing an increase in intra-abdominal pressure. And some patients will complain about unconscious incontinence, but that really ends up just being stress incontinence with the daily activities of, like standing up from a seated position, things like that. And it's a clinical diagnosis. You do not need urodynamics for this diagnosis. And there are different treatments we can use. So pelvic floor exercises is, always what I start with, because you always want to start with something conservative. And this can be, the Kegel exercises that the patient does at home on her own, or biofeedback, which is done with a device in the vagina, or pelvic floor physical therapy, in which a trained pelvic floor physical therapist does an internal exam and then directs exercises and stretches. If the exercises don't work, then you can move on to a bulking injection or a sling typically. And I mostly place mid-urethral synthetic slings because there's greater morbidity with the fascial sling due to the need to harvest fascia. And I know that synthetic slings are not available everywhere in the world, but they are something that I like to use in the US. There's also the option of a Birch procedure, which is an abdominal approach to a retropubic urethropexy, and that's been shown to have equivalent efficacy to slings in the Sister trial. The Birch procedure, though, that's really used less frequently than a sling because it requires an abdominal approach, and that is just more morbid. I do want to mention that there's the potential for disruption of the Skene's gland, just when you're operating anywhere near the female urethra. And there's, if you disrupt the Skene's gland, there's concern for associated sexual side effects. And that would be procedures like a sling placement, like a periurethral bulking injection. But in my review of the literature, I really didn't find much. It's really lacking regarding this theoretical risk. And the majority of the literature shows that surgical management of stress incontinence is improved in sexual function. And maybe that's just, due to the improvements in urinary issues, like if there's less concern about coital incontinence, the sexual function will be improved. So I want to go into some of these in greater detail. Next slide, please. This is an image of a urethral bulking injection. And here you can see before the injection, the patient does not have good coaptation of the urethra. But after the injection, the patient does have good coaptation. And this can be done under local anesthetic in the office or under sedation. And there are different materials that can be used, including collagen and hydrogels for this injection. Next slide, please. And this is an image of a sling. And I like to use this image when I explain to patients what the sling is doing. It's definitely an oversimplification, but I explained that stress incontinence is leakage with increased abdominal pressure due to a weakened or torn pubourethral ligament. And so then it sort of makes sense to the patient that we're using this sling to replace the support. And the synthetic slings are made of polypropylene mesh, and they have over 20 years of safety data. And here in the US, the FDA transvaginal mesh notification specifically stated that no conclusion could be made about slings. I know that's different in other parts of the world. And, it sort of makes sense that slings don't have the same risks that mesh for prolapse does, because while they are placed transvaginally, they're just less mesh burden due to their smaller size, and they're not exposed to the same loading forces as mesh placed for prolapse. But still, anytime you're putting a foreign body into the patient, there is a risk of issues. For example, risk of mesh erosion, which is to say that the mesh peeks out from under the vaginal epithelium where it was placed. And this can certainly cause dyspareunia. And usually it's treated conservatively, first with vaginal estrogen cream, but ultimately it may require excision of the eroded piece of mesh. A fascial sling would look similar to the synthetic sling in this image, but it would be placed at the bladder neck, and it's made of fascia, and so that can either be rectus fascia or fascia lata, but again, it's more morbid because there's also a harvest site. So, which is a better choice for a patient with regard to sexual function? In a secondary analysis of a prospective cohort study of the midurethral slings versus bulking, they looked at the PISQIR, which is the Pelvic Organ Prolapse and Urinary Incontinence Sexual Function Questionnaire. And they found that the PISQIR improved following both interventions. And they corrected for differences in baseline characteristics and found that the PISQIR summary score at 6 and 12 months was similar for both groups of patients. So, that says that there's not one choice that's better than the other. And the authors of this study concluded that the improvement was due to decreasing the impact of stress incontinence on sexual activity. So, for example, when a patient who was otherwise worried about coital incontinence is no longer worried about that, they have improved sexual function. Next slide, please. So thus far, we talked about the most common causes of incontinence. That's urgency incontinence, when a patient leaks with urge, and stress incontinence, when a patient leaks with increased intra-abdominal pressure. But there are some patients who complain of continuous incontinence. And of course, like I mentioned before, some patients say they're wet all the time, but actually they're only leaking with certain activities, like standing from a seated position or even shouting, which increases the intra-abdominal pressure. But there are patients who truly are leaking continuously, and that would be a fistula. Next slide, please. Fistulas typically occur from trauma or tissue damage, which can be from obstetric injury, a surgical injury, or radiation or malignancy. And vesicovaginal fistulas in the developing world often occur as a result of obstructed labor that leads to ischemia in the surrounding tissues. Here in the US and in other developed countries, they're more commonly seen as a result of, for example, radiation to the pelvis for a cancer or a result of surgical injuries at the time of a hysterectomy or C-section. There are also ureterovaginal fistulas, more commonly related to surgical injury, for example, during a C-section or hysterectomy, and vesicouterine fistulas, also typically due to surgical injury, for example, as a result of a C-section or a myomectomy. Next slide, please. In order to figure out what kind of fistula you're dealing with, you typically want to do a double dye test. And so this involves giving oral phenazopyridine, and that's going to turn the urine that comes down from the kidneys orange. So the ureters have now turned orange. And then you place a tampon or a gauze in the vagina and backfill the bladder with a dilute methylene blue. So the urine in the bladder is blue and the urine in the ureters is orange. And when you remove the tampon, the color tells you what kind of fistula you're dealing with. So for example, if there's blue, you're dealing with a vesicovaginal fistula. If it's only yellow, you're dealing with a vaginal ureteral fistula, or you may be dealing with both if you got both colors. And if there's only a small amount of blue at the distal end of the tampon, it may just be leaking through the urethra and not truly a fistula. I also use physical exam here. I use cystoscopy and even MRI as needed to make the diagnosis. And depending on the type of fistula, the patients may require repair via a vaginal or abdominal approach. Next slide, please. So this photo is showing a vaginal approach, and the decision regarding approach is really based on the location of the fistula and a little bit of surgeon preference. So if it's a distal vaginal fistula, then a vaginal approach should be used. If it's a more proximal vaginal fistula, then you might want to use an abdominal, laparoscopic, or robotic approach. And the basic principles of fistula repair are to excise the fistula tract, close the bladder in a watertight fashion, and close the overlying tissue in as many layers as possible, perhaps using a tissue flap or interposition. And there are different types of interpositions like a Martius flap, gracilis flap, peritoneum, and even omentum. Next slide, please. If the fistula is between the ureter and the vagina, if it's small, it can sometimes be managed conservatively with a ureteral stent. But if this fails, then the patient will require a ureteral reimplantation in which the healthy ureter above the level of the fistula is transected and reanastomosed to a different location on the bladder. And this here shows a vesicouterine fistula. And they've filled the bladder with contrast, and you can see that the uterus fills as well. And this may present with cyclical hematuria or amenorrhea, or even continuous incontinence, although that's not necessarily the case. And often this type of fistula can be managed with a hysterectomy if the patient is done with childbearing, or if not, you can do excision of the fistula tract and repair of the uterus and bladder if the patient is interested in future fertility. Next slide, please. And in a retrospective review of patients with vesicovaginal fistulas who'd undergone surgical repair, more than a third had sexual dysfunction after surgery at a mean of 2 years, which is really quite a high number. And transabdominal and transvaginal approaches had comparable FSFI scores. So this really stresses that, the best approach to the fistula depends on where the fistula is and what the surgeon feels comfortable with. And interestingly, in that study, multiparity was the most significant predictor of sexual dysfunction, but the fistula characteristics were not. Next slide, please. So today we talked about the various types of incontinence and the surgical management options for them. I think the most important take-home message here is that pretty much every surgical treatment for incontinence improves sexual function. And so while there are variations and improvements seen with some treatments affecting certain parameters or certain domains of sexual function, but not others, and some authors suggesting that the improvements in sexual function are simply due to improvements in incontinence as compared to independent effects of those treatments on sexual dysfunction, the big take-home point is treating incontinence improves sexual function, so we should not hesitate to offer treatment for incontinence with surgery to our patients who are suffering. Thank you.
Thank you. Thank you, Alison. I particularly like this very clear take-home message. And thank you also for reporting this list of references. Okay, so now we will move to our next and last speaker, Dr. Anna Padoa, MD. She's a urogynecologist and chair of the pelvic floor unit at the Chen Shiba Medical Center in Tel Aviv. She will talk about surgery of pelvic ovum prolapse. Thank you, Anna.
Thank you. Thank you so much for the kind introduction, and I thank you very much, Elisa, for the invitation. Thank you to Elisa. Thank you also to Daniel. So I'm very honored to be here and talk about pelvic organ prolapse, which is one of my topics. It's actually my bread and butter. That's the way I make a living, treating prolapse. So the big question is, what is the best surgery for sexual function in a woman with pelvic organ prolapse? These are my disclosures. So it seems like whoever is taking surgical care of the vagina and the surrounding pelvic organs should be very, very familiar with the sexual function, sexuality, and sexual medicine. Unfortunately, this is not really true. In many urogynecological practices, there is not enough discussion about sexuality, both in general terms and especially preoperatively, which may have a significant impact on setting the right expectations following surgery. So it's an issue that we've been talking about in the urogynecological community for during the last years. There's a lot of obstacles when approaching sexual function on the sides of surgeons, of urogynecologists. There's the fear to offend the patient by asking very private questions. There's, in many cases, a low recognition that a healthy sexual activity is important, especially as we treat women who are more of an advanced age. So we kind of assume sometimes that their sexuality is not so important anymore. Also, there are time constraints, and we know that taking a sexual history takes time. There is inadequate or not really thought of reimbursement for these consultations, very little training for urogynecologists on sexuality. And I hope that this webinar and the next ones and other cooperations will improve the connection between the two fields. Also, quite often, urogynecologic clinics lack privacy, which is needed very much when we talk about sexuality, and sometimes cultural barriers and personal discomfort on the side of the surgeon and the patient prevent this discussion. Of course, the classical, very old-fashioned but still working implicit model may be implemented in a urogynecology clinic as a very basic way to address the topic, as quite often in this field, women won't raise it themselves. So when we decide to address sexual function, in many cases, it is easier to use questionnaires, and of course, questionnaires are important if we want to measure our success or our failures in this field. So I brought you a list of well-established tools that can be utilized in a urogynecological practice. They must be, of course, administered before surgery if we want to know what the result of surgery will be. So when we meet a patient with pelvic organ prolapse, there is a kind of a flow chart of decisions we need to take. And this is just the surgical part of the flow chart. There are always three options with a pelvic organ prolapse patient. One option is watchful waiting, because there are very rare medical conditions in which we really need to suggest surgery as a treatment option. Then there's the other gold standard option, which is surgical treatment when the prolapse is asymptomatic. And there is another option in between, which is pessary treatment, which should be really offered to every patient, regardless of their age or status, as this is a legitimate option also in women who are sexually active, and this should be kept in mind. Once our patient decides that she's interested in surgery, the first important decision is whether sexual activity for her will be important in the future and what type of sexual activity is expected by her to have in the future. There are women who are interested in full intercourse. There are also women who may be sexually active without vaginal intercourse, and especially in women of advanced age who are not interested at all in future vaginal intercourse, the option of obliterative surgery should be offered, which is a very safe surgery, and it's very effective. Probably by evidence shows that it's the most effective surgery to treat prolapse, and it can give very good results to anyone who is not interested in future vaginal intercourse. But this is just maybe 5% or at the most 10% of our patients. Most patients will be happy to have the future option for vaginal sexual intercourse. And so we would usually recommend reconstructive surgery. When we decide upon reconstructive surgery, there are two basic options to offer. One is the vaginal approach, and the other one is the abdominal approach. Once again, both options are legitimate, and surgeons may prefer one of the two according to their skills and expertise. But we should keep in mind that the vaginal approach is always the safest approach to treat pelvic organ prolapse, as the vagina is a natural orifice, and we don't need to go through the abdominal wall. And the other option is to have an abdominal approach, which is today mostly minimally invasive, so much safer than in the past. But keep in mind that minimally invasive, it's not always really totally safe, and we can still have injuries of internal organs or blood vessels. We tend to go for an abdominal approach in younger and sexually active patients, or in patients with recurrence of the prolapse following vaginal approach. And in the typical index patient, we will mostly, at least in my practice, offer a vaginal approach, which is really could be also very good for sexual function. Once we decide upon a vaginal approach, there is an option to do a graft augmented repair. There have been a lot of concern about complications following grafts, vaginal grafts, and so after alerts issued by the FDA 2011, later on, several years later, there was a kind of decision to stop manufacturing and selling grafts for vaginal surgery for prolapse. And so this is just one option that is kept like a niche for very, very selected cases. Now we will move on to see what happens with the pelvic organ prolapse surgery and sexual function, and what we know from clinical studies. So there have been some systematic reviews and meta-analysis in the last year addressing this topic. So we know in general that sexual activity and sexual function usually improve or at least stay similar after pelvic organ prolapse surgery. And in general, when we meta-analyze data, we see a general decrease in dyspareunia after all surgery types. Now we will zoom into the different surgery types, because it's not so simple as it looks. There are several reasons why postoperative sexual function may be impaired after pelvic organ prolapse surgery. We have organic reasons and psychosocial factors. So the organic mechanisms may be anatomical or physiological, mostly anatomical, I would say. There is a theoretical risk of injuring vascular and neural structures, which I think has not been proved as a main mechanism, although sometimes we can see pudendal nerve injury following pelvic organ prolapse surgery, which may have a significant impact. And then there are hormonal factors which are not directly related to surgery unless we go for a surgical menopause and do not give hormonal replacement to the patient. And then we may see the effect of genitourinary syndrome of menopause combined with the effect of surgery, which is usually has a deleterious effect. Then there are studies showing that there are a lot of psychosocial reasons why women after pelvic organ prolapse surgery may have a decrease in sexual function. They may be stressed following the surgery. They usually we find in studies a comorbidity with anxiety and depression after surgery when there is a decrease in sexual function. There is a perception that sexual intercourse may be dangerous after pelvic organ prolapse surgery, either dangerous to the woman herself or dangerous to the surgery with fear of injuring internal organs. So this has been shown by several studies, both qualitative and quantitative. The same group issued a new systematic review 1 year after the previous one. And this systematic review was a little bit more interesting to me because it kind of showed in more like detail comparisons between several types of different surgeries. So you can see on this slide that if you look at the bottom of the flow chart, there's not so much material about this topic in general. So there's not so many high quality studies as we would expect. Anyway, they managed to carry out this systematic review and get to some conclusions. So the basic messages were that when transvaginal mesh was compared to native tissue repair, there were studies that combined brought us to a cohort of almost 8,000 women, which is quite a lot. And they found no difference in postoperative dyspareunia between vaginal meshes and native tissue repair, and there was no difference in postoperative sexual function between groups. But in another comparison, when transvaginal mesh was compared with sacrocolpopexy, which is the abdominal, minimally invasive mostly approach, what was shown was that total postoperative dyspareunia was higher, significantly higher after vaginal mesh than after sacrocolpopexy, 27% with mesh versus 12% with sacrocolpopexy, and that there was a big issue with de novo dyspareunia, but it was not so different. It was reported but by very few studies, and it was found both after mesh and after sacrocolpopexy. The comparison between the abdominal approach and the vaginal approach did not show a statistically significant difference between the two approaches. So we may say that both vaginal native tissue repair and sacrocolpopexy are safe surgeries for future sexual function. Next slide. So the vagina has different segments, and we need to look at them differently, and it's difficult to assess the effect of surgeries according to vaginal segment, because quite often the surgeries are carried out in combination for the different segments. As a general rule, we know from studies that the anterior vaginal wall, when it's corrected by native tissue repair, so without meshes, does not appear the correction to impact adversely sexual function or cause dyspareunia. Regarding the apical segment, the usually most well-established approach is that if we have a patient who is young and sexually active, and her sexual activity is an important part of her life, sacrocolpopexy may provide an advantage, as we do not carry out incisions in the vaginal walls, and we may kind of be able to preserve more flexibility of the vagina and less scarring and less potential injury to neural structures, and of course less scars, which may be painful in sexual activity. So this may be the best approach for young and sexually active women. But as I showed you already, also native tissue repair with a vaginal approach has been shown to be safe for sexually active women. Regarding posterior vaginal wall repair, there have been several studies showing that about 1/3 of women who undergo posterior vaginal wall repair using muscle tissue, so usually the levator ani plication, this is the typical procedure which was very common in earlier years. About 1/3 developed de novo dyspareunia, so new pain on sexual intercourse. So it is quite clear to everybody today that levator plication should be avoided when sexual function is important for the patient. Some more studies that can be interesting on different vaginal segments. So on the anterior wall, there has been an interesting a study by Feldner in 2012 comparing with an RCT native tissue repair and small intestine submucosa graft. We don't use so much biological grafts anymore because they don't provide an advantage anatomically and a subjective outcome as compared to native tissue repair, but at least they do not do a lot of damage. So we saw from this study, for example, that that was limited to the anterior prolapse repair, that both techniques were safe in terms of sexual function, and there was a similarly good improvement in both groups. Another study by Vollebrecht from Scandinavia was also an RCT comparing women with the anterior vaginal mesh and native tissue repair, showed that differently from a biological graft, an anterior mesh can be deleterious in terms of sexual function. And there was an improvement in pain, lubrication, and satisfaction in the native tissue repair group, while this improvement was not observed in the mesh group when assessing pre and post surgery. And there was a significant percentage of women in the mesh group, as you see, 43%, who had a worsening of sexual function following surgery, which is an important information to keep in mind. So this is a busy table, but you can have a look at the numbers that in the last column, which I highlighted in red. So you can see that following vaginal mesh, which we use very rarely today, there have been very alarming data on a decrease in sexual function, of high rates of dyspareunia, new onset dyspareunia, and this is true especially in young and sexually active patients. So I suggest a lot of really being careful not to consider too easily this kind of surgeries in young and sexually active patients. Next slide. And once again, the risks of vaginal mesh. Of course, vaginal mesh, which is implanted, can be removed, but we know that resolution of the pain can be achieved only in about half of the patients, and that about 1 in 5 patients will have persistent pain. And sometimes even after removal, there can be worsening of the pain. And so I would not say that it is a problem that is easy to solve when we have a mesh causing pain and dyspareunia. Next slide. Going now to the posterior segment, I already mentioned the negative effect of the levator myography in the posterior wall. There are a couple of studies which I want to mention that have assessed specifically the posterior repair and the effect on sexual function. So a study on 68 patients of a median age of 72 years who were administered the FSF5 before and after repair of a posterior prolapse. And there was improvement in some of the domains, and no change, at least not worsening, in other domains. And this was done by a technique of plication and not levator myography, like not levator plication. And another study which really shows that, which also shows about the effect of surgery on the posterior wall, was done by Paraiso. They had a follow-up of 1.5 years. So they carried out the correction with the native tissue repair and biological graft, and they found improvement postoperatively in both groups. So when we use a standard fascial plication and not levator myography, we will have usually a good outcome. Next slide. This is once again a study showing that the posterior repair following levator plication can cause a lot of damage, with improvement in dyspareunia in women with a levator plication. Next slide. What about hysterectomy? So hysterectomy, there's always a discussion at sexual medicine meetings about the risk of carrying out a hysterectomy and the deleterious potential effect in sexual function. So it seems that when sexual function is a good sexual function before the surgery, usually hysterectomy should not have a negative impact on sexual function. In some cases, when there's a bulky myomatous uterus, there may be an improvement in sexual function, and in dyspareunia, there could be a reduction in deep dyspareunia, especially. In some studies have shown worsening of sexual function following hysterectomy after vaginal surgery, vaginal hysterectomy. The reason is that in many cases, the colpotomy, which is done to remove the uterus, takes out a lot of vaginal skin. So this is why it is very important to measure total vaginal length before and after surgery, and to take care to keep very close to the cervical os when performing a vaginal hysterectomy to preserve total vaginal length and not shorten the vagina, which may cause, of course, dyspareunia. Regarding colpoclasis, of course, colpoclasis is preclusive of future sexual vaginal intercourse. And there is a lot of discussion about regret rate on closing up the vaginal lumen in women. So usually my practice is, I tend not to offer this kind of surgery to a woman who's less than 80 in general. So if someone really is, elderly, definitely if she's frail and has absolutely no interest in future vaginal activity, then this is a good surgery, but there should be a clear discussion about it. There are studies showing that women who have kind of sexual activity without vaginal intercourse may have a definite improvement in sexual function following colpoclasis, because they don't have this bulge coming out from their vagina, and they feel better with their body image, which is maybe the most important element impacting sexuality in pelvic organ prolapse. Next slide. This slide shows the main studies published on sexual function following sacrocolpopexy, and you can see that mostly and consistently sacrocolpopexy is a very good option for sexually active women, and there is improvement across all studies done, and it is widely accepted that this is the best way to correct a prolapse when a woman is young and sexually active, and we want to maintain vaginal elasticity in the best possible option. And this is an important and interesting study because it's a prospective longitudinal cohort in a very large group of patients with variety of pelvic organ prolapse surgery procedures assessed in 35,000 patients. So these patients were administered the PSQ-12 questionnaire at baseline, and then at 6 months, 2 years, and 5 years after surgery. So there's also long-term follow-up. So what they showed in this study was that the proportion of sexually active women increased from 40 to 43% after surgery. So it seems that this is a very small increase, and it is important to keep in mind that usually if someone's genital self-image is not impacted, prolapse by itself should not be something that disturbs completely sexual activity. A lot of women, even with quite advanced prolapse, can have satisfying sexual intercourse. So we shouldn't promise, a complete and huge change to most women following surgery. In preoperative dyspareunia, which women reported on, was resolved in more than 50% of women after the first 6 months following surgery. And the novel dyspareunia rates were observed to be low at all time points. Risk factors associated with dyspareunia after surgery were younger age, lower BMI, lower prolapse stage at baseline, and this is very important, pelvic pain or dyspareunia at baseline, and this is maybe the most important element, prior surgery, and posterior repair, as we already discussed in the previous slides. Next slide. Now, I wanted just to give you a little bit of my experience, from clinical practice, my gut feeling, because, quite clear that the meta-analysis show us that most surgeries are okay for sexual function. But I would like to stress some points that I learned from practice, from good things that happened to my patients, and from less good things that happened. So when performing vaginal hysterectomy, I remember at the beginning of my training, I saw surgeons really taking out a big chunk of vagina together with the uterus, with the feeling that sometimes when there's prolapse, there's this big stretching. So we have a lot of redundant tissue, and we should not be afraid to take it out. So I learned not to take out vaginal tissue almost at all and keep as much as possible, as if we do an appropriate suspension, the tissue will contract. So avoid removing tissue, definitely if you're using a mesh, but also with native tissue repair. So keeping colpotomy when we remove the uterus very close to the cervical os. In the younger population, I mentioned the option of sacrocolpopexy as the best one, but I must say that in my experience, especially when there are those quite young patients between 40 and 50 with elongated cervix, and sometimes a little bulky uterus that is not really descending. So they have quite good uterosacral ligaments, which are quite well preserved in many cases. So I think that in those cases, a high uterosacral suspension is a very good option, as it provides a very physiological vaginal axis and a quite flexible vaginal lumen. Another option, if we want to do a uterine preservation, may be a Manchester operation, which has been shown to be very effective for apical suspension, especially by Scandinavian groups. And both of those may provide a more natural and dynamic vaginal axis than what we do with sacrospinous ligament fixation or suspension, which I love. I mean, I love this surgery. The sacrospinous ligament suspension with the suture capturing devices is amazing, but it's maybe not the best for a very young and sexually active woman. Then the other thing I would like to say is that especially when we combine the anterior and posterior colporrhaphy, we need to really be careful when we freshen up the edges, because then at the end you do a vaginal exam and you realize that you've created a mid-vaginal contraction ring. So in many cases, for example, when you have a rectocele repair and after a couple of years you carry out an anterior repair, because then she has a cystocele, which is a second primary actually prolapse, and you correct the cystocele, keep in mind that the posterior vaginal wall is scarred. So if you resecate and kind of freshen up a lot of edges, you're gonna cause constriction of the vaginal lumen. Regarding the genital hiatus, in many prolapse patients have a very large genital hiatus. So we assume that they must suffer vaginal laxity. So vaginal laxity is a very poorly defined condition, and we should ask about it. In many women, especially women who are postmenopausal, this laxity may be the one allowing sexual activity, because it is in combination with genitourinary syndrome of menopause. It kind of decreases the effect of the genitourinary syndrome of menopause. We know that the GSM is much worse in women who have a small genital hiatus, in women who have not given birth, or women who had only cesarean deliveries. And I must say that I had a very traumatic for both sides experience of reducing the genital hiatus in a woman who was in her 70s. And it turned out, it was back then when I didn't ask about sexual function, that her husband had some moderate erectile dysfunction. He didn't want to take any medications. So a 5 centimeters genital hiatus allowed intercourse. A 3.5 centimeter genital hiatus did not allow it. He was unable to enter her vagina anymore after the surgery. So I'm very careful about this kind of surgeries today. And another last thing is that when we do sacrocolpopexy, we need to be careful when we use multifilament permanent sutures, because they may be one of the reasons why we see sometimes erosion of mesh and sinus tract through the vagina. And this can be very, very deleterious for sexual function, even if we did the best surgery available. So this is all my talk. Thank you for your attention, and I'll be happy to take your questions.
Thank you, Anna. To ask Kern regarding the synchronous surgery that you talked about. Are you here? Yeah.
Yes.
What is practically the candidate, the patient you would say that is the perfect candidate for this kind of surgery?
Elisa, first, can I start my video, or you don't want me to start it?
Sure. I didn't know that you had the video.
I cannot. Okay, it's okay.
Okay, yeah, sorry.
So, can you please repeat your question, Elisa?
Can you summarize practically which is the best candidate among the patients that we may have in our clinical practice for the synchronous surgery? Yeah.
So the classical patient is a patient after radical prostatectomy, and the patient that is an indication for a double implant is the patient who has at the same time a PDE5 or conservative treatment non-responding erectile dysfunction, and a stress urinary incontinence non-responding also to conservative therapy.
Great. And do you have any data on partner satisfaction after this kind of procedure?
Well, yes, we do have data on partner satisfaction. This is a good question, but not, as far as I know, not concerning incontinence. So if we talk about, and this makes sense, of course, that incontinence is not really affecting the partner's quality of life. So only for the erectile part, we do have a lot of data on partner satisfaction. And partner satisfaction is in most series at least 80 to 90%.
And compare with other kind of treatment for difficult ED, for severe ED?
Well, this is of course not available for the double implant population. Yeah. But if we talk about the total erectile dysfunction population and we compare PDE5 inhibitors and vacuum device and intracavernous injection versus penile implant, then we do know that the penile implant is by far the most satisfying option. I published a paper, I guess 1 or 2 years ago, and this was striking to see. This was, of course, retrospective, because the question to the patient was, would you have preferred to have your penile implant earlier? And if so, how much earlier? So when a patient had a penile implant, the question was, you have it now, would you have been more happy if you had the implant earlier? 50% of patients, and regarding your question, partners, so 50%, half of the patients and their partners wanted to have a penile implant at least 5 years earlier, because the other options, PDE5 inhibitors, vacuum device, intracavernous injections, were not as satisfying neither for the patient and the partner compared to penile implant.
Okay, thank you. I see that Alison has a question for Anna. Is that correct? Please, you can activate your microphone.
Thank you so much.
Yes. So I found it very interesting that you said that you don't resect any of the vaginal wall skin. And I was wondering 2 things. One, do you develop hematomas? Because now there's sort of like a dead space between where you plicated the fibromuscular layer and the excess, skin. And the second thing is, I always assumed that if you didn't resect it at the end of the case, you'd look and you'd say, oh, it looks like I didn't do a good prolapse repair. But you're saying that it actually scars in, so that it Even
Okay.
if it doesn't look good in the operating room, it looks good 2 weeks later?
Yeah, all right. So thank you for the question, because it seems I was not clear. I do resect, okay? I do resect the skin. I was talking about several different things. What I said that when I said that too much skin is resected, I meant when we do a vaginal hysterectomy, right? We take like a circular colpotomy around the cervix. So when I was a trainee, I remember that this colpotomy started like 5 centimeters from the external os. You may remember it too, although maybe you were a trainee a few years after I was, so maybe this already changed by then. But now I try to teach my trainees to keep as close as possible to the external os, because the skin that goes with the sacrospinal suspension or the high uterosacral suspension gets really deep in the pelvis. It's going to be helpful for the patient. It's needed. This is one thing. When we talk about level 2 defects, which is the cystocele, anterior wall prolapse, and posterior wall prolapse, usually we need to resecate some of the skin, but we always cut too much. Always cut too much. And I've been more sorry of having cut a little bit too much than having cut a little bit too little. Now, usually I can say that if you plicate the anterior wall with the 2 layers, I don't know, there's many techniques to do that. I use a PDS interrupted suture layer, and then I do a second layer with Vicryl. That's how I do it. And then usually there is not such a big dead space in the anterior wall. In the posterior wall, if I notice that there's a little bit more of bleeding, because that's a more bloody area usually, then what I do is that I take a little bite of the when I close the vaginal skin, I take a little bite to close the dead space of in the plication area before I take the other edge. You know what? You understand what I mean?
Yes, I do the same thing. Yep.
Right. So that's a trick that we use. And again, I think that if we do only anterior colporrhaphy, then it's going to be okay, even if you've reseccated a little bit more than needed. But if you do both anterior and posterior, then you're going to have that moment where you check with 2 fingers and you feel something constricting at the mid-vaginal level. And sometimes this is clinically significant after surgery. And if you have a 45-year-old, it doesn't really make a difference if she's got still estrogen helping healing. But with a 65-year-old, it may be a problem. She will have pain, and this will be a good occasion for her to stop sexual intercourse altogether. That's in my experience.
Yes, I agree. And I think that I have also, I'm thinking about it now, I've done things where I'm doing a posterior repair, and I think that the genital hiatus is maybe, 3.5 centimeters at the end of the case, and I feel good about it. And then I see the patient back, maybe 3 months later, and I realize it's 2 centimeters, and I say, how did that happen? But I think it's scarring over time. So I think that's a really good point. And then the other technique that I was thinking when you were talking about the vaginal hysterectomy is sometimes in a patient with cervical elongation, I actually will make my incision close to the os and then undermine the skin on the cervix so that I can preserve as much as possible. And other people think,
That's
oh,
what
why
I
are you
always
preserving that
do.
skin? But it's better to have extra.
Look, I completely agree. That's what I do. Although the people who taught me, they used to go with the diathermy, with the bovi, up to and take out the skin altogether with the cervix. Of course, it's shorter and easier, but I do it like a vaginal hysterectomy. I just go below the skin when I do a Manchester, so I can keep all that precious tissue that can add flexibility to the vagina and not shorten it. I don't know.
Yes.
I'm happy that we agree on that.
Yeah,
Absolutely.
it was great to see 2 urogynecologists confronting on a topic. So thank you. Alison, I wanted to ask if you could comment briefly on coital incontinence. Is it a subtype of stress incontinence? Do we have specific diagnostic criteria or a process of care?
So it's interesting because I, was trained to think that it's a type of stress incontinence, although I was talking to a colleague of mine the other day who said that he was trained to think that it was a type of urge incontinence. And so I think, for me, when I have a patient who complains of coital incontinence, the first thing I say is, it's okay, because there are some patients who say, I have coital incontinence, but my partner finds it, to be stimulating. Is that okay? I say, whatever works for you is okay. There's no rules. And then I say, if a patient is bothered by the coital incontinence, start with behavioral things. And that was sort of one of the things I was trying to touch on in my talk, is not everything has to be surgery. And so if you can start with behavioral things like avoiding, drinking a lot before sexual intercourse, making sure you urinate before sexual intercourse, and then, you can try pelvic floor exercises, because that may also be helpful for the stress incontinence, if it is stress incontinence. And then beyond that, there's also discussion of, is it truly urine? Is it fluid from the Skene's gland? And, I don't know that there's any good data to say that definitively it's one thing or another.
Okay. That's great. So thank you, everyone. I would like to thank our 3 excellent speakers and all the participants. And please, I would like to remind about our joint ESSM meeting, which will take place in Porto in February 2026. And I was particularly fond of this webinar, since I am actively serving both societies, and I think it was very engaging presentations and discussions, and I hope to see everyone in Portugal in February. Thank you.